Well, good morning, everyone, and thank you, Alina and Raymond, for inviting me. It's great to see everyone. It's great to see a lot of familiar faces, and it's great to see a lot of new faces. And so, the objective of my talk is to talk about the biology of CLL, is to talk about some of the investigations we do in CLL, and I have resisted the urge to talk about treatment, because Dr. Gary will go into that, and as you all know, it is very complicated. So, I'll go over the biology of CLL. I think a lot of this will be very familiar to everyone, but hopefully everybody can take a little bit from this talk. So these are my disclosures. I have partnered with multiple pharmaceutical industries over the years, and that has allowed me to grow my own research career, run clinical trials, and basically collaborate and be part of events like this. So today we'll talk about how is CLL diagnosed? What is the natural history of CLL? We'll talk about the heterogeneity of CLL. You'll hear me using the word heterogeneity a million times. We'll talk about what tests typically we do, when we do them, why do we do them, what do we not do, even though people want us to do them. We'll talk about prognostic markers in gene tests, because I find that's a bit of a black box for people. We'll talk about active surveillance, which is a very anxiety-generating topic for many. And we'll talk about indications for treatment. So off we go. So let's start with the very beginning. We are talking about a malignancy of the immune system. And so the most obvious starting point is, well, what in the world is the immune system? Well, this is a diagram that shows the distribution of the immune system. And the immune system is designed to protect us from things that don't belong: bugs, toxins, cancer cells. And the immune system is essentially from head to toe, not only in lymph nodes, but in other organs like the bone marrow, the spleen, and also in tissues like the bowel, the lung, the tonsils. And so when a patient is diagnosed with a lymphoid cancer, and specifically with CLL, they almost always have advanced stage disease. And so patients often have a panic attack when they ask me, what is my stage? And I say, it's stage 4. Well, yeah, this is an immune system malignancy. And so by default, it is going to be found from top to bottom. That might not be the case with aggressive lymphomas, but in CLL, this business of stage, to me personally, doesn't make a whole lot of sense, because you're dealing with a systemic disease. Now, okay, fine. But let's zoom a little bit more into this business of the immune system. So immunity, and I should say acquired immunity, is driven by a whole army of cells. And these include cells that recognize the bad guys. It includes cells that kill the bad guys. It includes cells that eat the bad guys. And so there's a whole host of cells involved in the immune response. And CLL is a cancer of B cells, which I'm showing in the box on the right. And the job of B cells is to generate antibodies, and the role of antibodies is to tell the rest of the immune system where to go and what to do when they find a bad guy. And B cells turn into plasma cells, which are cells that produce these antibodies. So you can imagine then, looking at this slide and the previous slide, that immunity is an incredibly complicated process. It's a well-orchestrated process. It's like conducting an orchestra with strings and winds and percussion and the whole thing, and everything needs to be tightly organized. And if something goes wrong, if the guy playing the violin doesn't do the right job, it's a mess. And this is exactly what happens with CLL. And so the general idea with the genesis of CLL is that you begin with a population of normal B cells, so shown kind of in the first column, healthy immune system. And then at some point, for reasons that nobody really understands, a few of these begin to proliferate. And they start to lose control over their ability to die when they're supposed to, over their ability to properly make antibodies, over their ability to connect with each other. And all of a sudden, you have a population of abnormal and dysfunctional B cells. Now, not a lot. So our cutoff is less than 5,000 cells per microliter. So you can imagine that's actually just a little bit. They're not malignant. It's just a population of cells that's not supposed to be there. And we call that a monoclonal B-cell lymphocytosis, or an MBL. And a lot of people roam the earth With MBL, I probably have it and I don't even know. And for the majority of people, having these extra immune system cells floating around has absolutely no clinical significance. But in a proportion of these patients, these cells that are already abnormal to begin with continue to acquire genetic changes. And at some point, there's more of them. At some point, you can measure more of them. It's still not a cancer. But at some point, it crosses a certain threshold and it turns out into a B-cell malignancy shown in number 4. And we call it a chronic lymphocytic leukemia. And the name tells you what it is. It's chronic because it's chronic. It's lymphocytic because it's a disease that's arising out of lymphocytes, as we already talked about. It arises out of B lymphocytes. And it's a leukemia for the simple reason that we find it in the blood. I'm sure many of you freaked out when you were diagnosed with a leukemia and your minds went to the movies of the 80s with a little child with acute myeloid leukemia. And that's not what you have, right? That's acute myeloid leukemia. This is a leukemia. And the word leukemia simply means we find white cells in the blood. And you can what I'm trying to get at here is that there's a spectrum. And you can kind of see how along the way, different people are going to present with different manifestations of disease. People are going to present with different blood counts because of the way that their own CLL develops over time. Eventually, this bubbles to the surface, and you need to decide, does this person have a diagnosis of CLL? And so how does one pick this up? Most of the time, by a good old blood count, the machine picks up extra lymphocytes in the peripheral blood that should not be there. And that's shown in the picture here. So when you look at a normal blood smear, you see white blood cells and you see B lymphocytes as shown there. And in CLL, you just see a lot of B lymphocytes. Now, you would think that having a lot of B cells and a lot of immune system cells floating around in your blood would be good. It's not. Remember, these cells are useless. They have lost their ability to do what B cells are supposed to do. So they not only pile up in the blood, they pile up in other organs, and they also cause a lot of immune dysregulation, a lot of immune suppression, and a lot of immune dysfunction. So the way we diagnose CLL is, well, you need to have a certain amount of cells, of malignant cells floating in the blood. They need to have the right profile on their surface. So that's why we do tests like flow cytometry, just to make sure that whatever's on the surface of those cells matches our understanding of CLL. And then we need to do some additional tests looking at the type of antibody that they're making. And so on the chart on the left, I have kind of like the standard criteria that we use behind the scenes in the lab to say, does this person have CLL? Yes or no? So then you've made the diagnosis of CLL, but you kind of need to think about the bigger picture here. These lymphocytes are not acting on their own. CLL cells are really, really sneaky and really tricky, and they interact with every single other immune system cell in the body. And so that's what I'm showing here. So here I'm showing the malignant cells in the center, and you can see how they're interacting with essentially the whole family. They're interacting with regulatory C cells, cytotoxic T cells, Nerd-like cells, T helpers, stromal cells, antigen-presenting cells, histiocytes, even blood vessel cells. So they're interacting with everybody. And what they're doing is they're generating what we call a microenvironment. In other words, they're generating an environment where they can thrive. And they thrive by communicating with everybody else, and in particular, by suppressing the good guys, by causing exhaustion of T cells, which are the good guys that kill cancerous cells. They thrive by messing up with cells that eat bad cells. And so it's a much more complicated process than just a whole bunch of abnormal B cells piling up all over the place. And then at some point, you begin to see the symptoms of CLL. So with CLL, you not only see abnormalities in blood work, like a high lymphocyte count, anemia, so low hemoglobin, low platelets. You also see these cells accumulating all over the place. So you see lymph node enlargement, you see spleen enlargement, you see liver enlargement, because they're accumulating there. And in addition to that, because this is a highly immunosuppressive malignancy, as I showed you in the previous slide, people get infections. People feel tired. People lose weight for no good reason. I've had a few patients over the years who, you kind of see them in the clinic and you see them lose weight for no good reason, and their families are worried. And this is exactly what CLL is doing. It's causing this inflammatory state where people feel generally unwell. It's not that you wake up one morning feeling unwell, but it's a process that happens over time. And often people don't even notice or their family members, because they're living with them. It's when they go out for a friend and they go, hey, you've lost weight, what's going on? So these things can reach a point where patients are sick and need treatment. So that's the presentation of CLL. Okay. Up until now, we've talked about CLL, but CLL, again, thinking bigger picture, is part of a much bigger classification of lymphoma. So CLL is just a tiny little sliver of what Dr. Gary and I do. So CLL is considered an indolent B-cell non-Hodgkin lymphoma. So I've showed it there in red, but you can see how it's part of this very big family of other malignancies. So we can't kind of lose sight of the bigger picture here. But, it's not that uncommon. You look at big international series of how prevalent or what's the incidence of CLL, and it's about 8% of the of the non-Hodgkin's lymphomas that we see. Okay, well, what does that mean? So if you look at the Canadian Cancer Society data, they have the most recent data they have is from 2022. But 4 years ago, almost 1,600 people were diagnosed with CLL in Canada. So if you do the simple math, that's about 4 people per 100,000. So it's relatively uncommon, but not completely uncommon. And remember, too, this is incidence. We're not talking about prevalence, because, one of the joys of CLL is that as our treatments get better, people are living longer and people are living better. So actually, we have a lot of prevalent cases of CLL. And I certainly have a lot of patients with CLL in my practice because they're doing better over time. CLL is typically diagnosed later in life. So the median age at diagnosis is 72, and you can see the distribution there. So basically, half of your patients are 70 plus, and half of my other patients are 70 and below. And there's a small population of young patients under, like in their 40s and 50s. They're not very common, but those people are out there. So that's kind of the general epidemiology and the general kind of presentation and biology of CLL. All of this to give you all a sense of how heterogeneous CLL is. All of this to give you a sense that each person with CLL has their own trajectory, their own biology. And when I see a practice with CLL in the clinic, I see a little bit of every face of CLL. I think of CLL, those cubist paintings from like Picasso, where he like paints a guitar and like the different angles of the guitar. CLL is a little bit like that. Everybody has a little bit of a piece of that painting. And so let's dissect out the heterogeneity of CLL a little bit more. So first, one of the earliest observations with the biology of CLL is that some patients have a leukemia. But not everybody with CLL has circulating abnormal B cells in the blood. In some patients, it just likes the lymph nodes. Why? Because that's its thing. And so we have 2 spectrums here. On one end of the spectrum, we have classic chronic lymphocytic leukemia. So this is predominantly a disease of bone marrow, and patients have at least 5,000 abnormal lymphocytes floating in the blood. In the other end of the spectrum, we have something we haven't talked about so far called a small lymphocytic lymphoma. So these are the folks who don't have a whole lot of lymphocytes floating around. Maybe they don't even have any lymphocytes floating around, but they still have the same disease with the same malignancy that decided to set up shop in lymph nodes and in organs and in spleen. And we call that a small lymphocytic lymphoma. And the name tells you what it is. It's a lymphoma. Lymph means lymphoid. Oma means mass. So they're forming masses in lymphoid tissue. It's the same disease, just different presentations, and we treat them the same. Sometimes, some of you might see in our clinic notes, people have a little bit of both. So we just say, oh, this patient has CLL, SLL. And so sometimes patients think they have 2 diagnoses. And the answer is no. You have one disease, just 2 faces of that disease. The other very kind of known observation about CLL is this idea of biology and this idea of behavior. So on one end of the spectrum, a lot of people have this very slow growing disease, this very indolent CLL that they live with for ages. It was diagnosed incidentally, and it's a background thing, and it doesn't really cause any problems. And maybe they need treatment once, but it's not, a very life-threatening situation, and they die with disease. And there's always a patient that I see in consult that somebody told them that they are going to die with, not of disease. And I always find that terminology a little bit tricky. On the other end of the spectrum, you have the badly behaving CLL. You have the badly behaving CLL that has bad biology. They have gene mutations like TP53 mutations. They haven't mutated their immunoglobulin. We'll talk about that. And on the super end of the spectrum, CLL can transform into an aggressive lymphoma called a Richter's transformation. Any low-grade lymphoma can transform into a high-grade lymphoma. And Richter's transformation in CLL, fortunately, is uncommon, but it's unfortunately, when you see it, really difficult to treat because it is full of genetic mutations associated with treatment resistance. So those patients obviously require treatment, and those folks die of disease. So I never say to my patients, you're going to die with CLL or you're going to die of CLL, because the truth is, I don't know. And a lot of this is something that declares itself over time. And a lot of this is something that you don't necessarily know at the time of the consultation, because CLL is a very dynamic disease that changes over time. Now, let's talk a little bit about this business of dying of disease. So what do patients with CLL die of anyway? So there's been a lot of international, I shouldn't say that, like registry studies looking at this. So this is an example from Australia. So here they looked at 1,100 patients with newly diagnosed CLL over a broad range of time, and they kind of saw, okay, well, what are these people dying of? Like half of them actually die of CLL. So that actually tells you that there are a lot of bad players here. 8% die of infections, and those infections are related to the immune suppressive effect of CLL on the immune system, and 19% die of other cancers. Skin cancers are very common in patients with CLL, and I have had actually a couple of patients die from skin cancers. And it's got to do, again, with immune surveillance and the ability of the immune system to recognize and deal with squamous cell carcinomas and melanomas in the skin. So patients with CLL, especially fair-skinned patients, need to be on top of their skin because of this business of skin cancer. So where I'm going with this is it's more than half of the patients. It's probably 2/3 of patients with CLL actually die of some consequence of the CLL. So it's not just Richter's, but it's other conditions. And, the other quarter is comorbidities because, as I said, 72% of the median age is 72%. So yeah, a lot of people are going to die of other conditions, not necessarily related to CLL. But just to make the point that this thing that you're going to die with CLL is not 100% true. And so this brings up a lot of questions, not just in terms of treatment, but it brings up a lot of questions in terms of survivorship that we will talk about this afternoon. How do you take care of yourself? It's not just taking venetoclax and acalabrutinib. It's what else do you need to do to protect yourself from these other causes of death? And we'll dissect that a little bit more this afternoon. Well, that's the doomy and gloomy part. The good news is that the survival of CLL is improving as time goes by. So this is the most recent data that I could find. So this is a study from the Americans with a huge SEER database, 50,000 patients. And so they broke it up by eras. And so in that chart, the way to interpret that chart is on the x-axis, you have time in years. And on the y-axis, you have the probability of survival. So at time equals 0, everybody's alive. And then time goes by. And as people die, the curves begin to drop. So in the ideal situation, if nobody dies, you're going to have a horizontal curve. Well, that's not what we have, but you can see how they drop. So you can kind of see the obvious. Things are getting better as time goes by. And in this data set, at the 10-year mark, about 60% of folks are still alive. Or if you extrapolate a little bit more, you could say that at the 12-year mark, about half of the people are alive. Okay, well, that's much better than when I graduated from high school, but it's still not great. There's still a significant loss of life expectancy in CLL. And I would say a lot of people with CLL do not die at the same age that a sex an age-matched person in the general population might. Now, this is all comers. And remember, I keep insisting on the fact that there's a spectrum of CLL. There's the indolent end and there's the aggressive end. So this is just all comers. So is there a way to tease that out a little bit more? Who are the good players? Who are the bad players? And over the years, different prognostic systems have been developed to try to get at this business of who's going to do well and who's not going to do well. And so some of you may be familiar with the Rice stage or the Binet stage. Those were kind of some of the older ways of assessing, is this patient going to do well or not so well? And you can see how they've been refined over the years. And the most recent one is this one called the CLL IPI. And I'll talk a little bit more about that. But you can see how it incorporates not just clinical factors, but now it's including beta-2 microglobulin, which is a blood test. It's including genetics. It's including p53 mutations. It's including the IGHV mutation. So it's a much more refined way of saying, hey, if you have X or Y of these factors, how are you going to do? And in 2026, it, for the most part, continues to be the most widely used prognostic system because these tests are done routinely. When you develop a prognostic score, you need to include variables that you can test for. So you can't go crazy, asking for a weird gene that can only be done by next generation sequencing in a lab in the States. Like you need to use, things that can be done all over the place. And these are standard tests that are done as part of the workup of CLL. So I think the CLL IPI is something that we still use in CLL. And it works really well at estimating how an individual might do. And so the way it works is it looks at this kind of panel of 5 variables that I talked about already. Each of them is given a different, like a point system. And you add up your points and you assign patients into low risk, intermediate risk, high risk, or very high risk. So again, I have a survival curve here, same concept as the previous one. And so you can see how the patients with low risk actually do well. So at the 10-year mark, so 120 months, that's 10 years, about 80% of them are still alive. And on the other hand, if you look at the very high risk, at the 10-year mark, nobody's alive. So it's a good test of how somebody might do. The problem with this is that, this was, to get to 10 years and to publish this in 2016, then that tells you that this was started 20 years prior when the therapies for CLL were totally different. So what does this look like with our current therapies? I cannot tell you because time hasn't passed. And because people are doing significantly better, it's going to be a really long time before I can show you what this curve looks like when people are diagnosed and treated with the therapies that we have available today. So then zooming in a little bit more into the genetics. So another face of this cubist painting is this business of the immunoglobulin. And people find this very confusing. So hopefully I'll make this as clear as I can. In terms of dissecting out the biology of CLL, so not is it in lymph nodes, is it in blood, is it indolent, or is it aggressive, but in terms of actual genetic abnormalities, CLL can be roughly classified into 2 flavors. The CLL that has a mutated IGHV on one end, and a CLL that does not have a mutated IGHV. We'll talk about IGHV, just setting the stage for the spectrum here. Patients who have a mutated IGHV, so about 60% of the cases, these folks tend to be on the more indolent end of the spectrum. They have low-risk genetics. They have a longer time from diagnosis to requiring first-line therapy. They respond better, longer, and deeper to first-line therapy, and they tend to live longer. And this is independent of the CLL IPI. Well, it's part of the CLL IPI. And on the end of the spectrum, you have the patients with an unmutated IGHV, and those folks have the more aggressive disease with kind of the opposite end of the spectrum. So what in the world is IGHV? So IGHV means immunoglobulin heavy variable chain. So I said a moment at the beginning of the talk that the role of B cells is to produce antibodies that identify the bad guys. And so the structure of an antibody has all sorts of little parts. It has heavy chains and light chains and variable chains and constant chains. And so the idea of this mutation is in the heavy chain of that component of the immunoglobulin. So here you have a B cell, a mature CD5 positive cell. So in other words, a cell that is turning into a CLL cell. Some of these CLL cells enter lymphoid tissue where they are exposed to these bad guys and they learn how to make antibodies, but not all of them do. The ones that have been, so the CLL that arises from exposure to antigen in the germinal center, those are the ones that are mutated. The ones that arise without that type of expected exposure for a B cell in development do not. Think about it this way. You have a population of CLL cells that are educated in lymphoid tissue, and you have a population of cells that is uneducated. Well, if you have a strike by doctors versus a strike from high school dropouts, who do you think is going to have the worst strike? Yeah, doctors are terrible, right? We're like, oh, so sorry. So, but it's the same idea. So these highly more sophisticated, more educated cells will respond better to treatment. These sophisticated cells will still retain some response to therapy, but also to immunologic effects. And so that's kind of the easy way of thinking about the two flavors of CLL. And so we always look for the presence of an immunoglobulin mutation in all patients of CLL. It's something that does not change over the course of disease, so you only have to test for it once. And in most people, it's something that you can do from a simple blood test. And that's the joy of treating CLL, is that the majority of the work you can do from peripheral blood. But if you have a patient with SLL, then that person requires a biopsy, and you can also do it from a biopsy. But this helps you understand the biology, and it helps you understand how that person might do it. Might not necessarily change what you do for treatment, but I think it's important information to have. So that's the immunoglobulin piece. Now, there's more to this, right? It can't be that simple as a yes-no variable. CLL is way more complicated and cancer is way more complicated. And so there's mutations all over the place in CLL, and there's mutations that affect everything. There's mutations that affect B cell signaling. There's mutations that affect response to death signals. There's mutations that affect how quickly a cell is going through the cell cycle. There's mutations in DNA repair, et cetera, et cetera, et cetera, et cetera, et cetera. And some people have all of them. Some people have a few of them. Some people have a little bit of this and a little bit of that. So everybody is different. So it's very complicated. So up until this point, I've talked about almost like a sliver of time, assessment of a patient with CLL, but there's an added layer of complexity here, and that's the time factor. CLL evolves as patients are exposed to therapy. The disease sees therapy and adjusts itself to therapy and figures out way to resist therapy, and takes and harnesses that immune microenvironment that I showed you before. So they really are sneaky cells. And so in this business of indolent to aggressive, as you patients get more and more lines of therapy, they actually, the behavior and the biology of the CLL changes, and it turns into a more aggressive disease. And that's a concept that I think is always very interesting to talk about, which is a concept called clonal evolution. And so just to walk everybody through clonal evolution. So here's a patient with a sample. This is a blood sample from diagnosis. And so let's just say that patient's lymphocyte count is 30, and the majority of those lymphocytes are just kind of clones not doing anything. This patient basically has 3 different clones, a good, an intermediate, and a bad clone. You give that patient treatment, and then that treatment works really well for the sensitive clones. The treatment doesn't even touch the resistant clones, but then that person has a response, and we celebrate it. The scans look better, the blood work looks better, people feel better, great. Time goes by, and these clones begin to grow. And at relapse, that patient has the exact same blood count, the exact same lymphocyte count of 40, 60, the exact same symptoms, the exact same CT scan, but the disease is completely different. And you can see how if you keep doing this over and over and over and over and over, you end up with these ultra-resistant cells and oftentimes a Richter's transformation because of this accumulation of excess mutations. So the assessment of CLL obviously is a longitudinal assessment. It's not only a one-time thing. So then let's be a little bit more practical and a little bit more real world. So I see a patient with CLL. Okay, what does one have to do at diagnosis and at every point when you're at a decision-making step along the way? History and physical, we talk about all of the symptoms. You kind of have to assess for all of that. We do general blood tests. You have to measure their lymphocyte count. You have to do their flow cytometry if you haven't done before. And you need to do the prognostic markers. So you need to do their cytogenetics. In other words, you need to look for things like their chromosome 17, chromosome 11, chromosome 13, chromosome 12, their karyotype, because we know that some of these chromosomal changes are associated with good and bad behaving CLL. You need to know their mutation status. As I said, that's something that you only need to do once. And at these days, we can do P53 mutation status by next generation sequencing. So that actually gives you a much better sense of what you do. But basically, every time you're treating someone, you kind of have to start again and make sure you have a fresh picture of where they're starting because of clonal evolution. You can have a person who started without a P53 mutation and as part of clonal evolution all of a sudden has a P53 mutation. These days, we're using BTK inhibitors. People can acquire resistance to BTK inhibitors through BTK mutations. You can pick those up in your gene panels. Does everybody need a biopsy? Not necessarily. Does everybody need imaging investigations? I would say for the most part, everybody needs some form of imaging investigations, although that's controversial. These are the current guidelines in terms of the investigations that one should do at diagnosis and that one should do at treatment decision points. And so it's broken down by what one should do in general practice and what one should do on a clinical trial. So just to kind of go through this, yeah, like you should always do a good history, physical, and blood work, and assess for disease, infectious disease status. So, for example, people who might have a hepatitis B or a hepatitis C infection, HIV infection, latent tuberculosis, people who have recurrent infections who might need immunoglobulin replacement. You should always test for your mutations. But this is the one that people find very controversial, is scans and the bone marrow biopsy. And notice how the guidelines say sometimes. And the reason for that is not everybody needs a scan. If you have true CLL with involvement of blood, maybe a little bit of spleen, but no notes, is a CT scan really necessary? No. Bone marrow biopsies are rarely necessary in CLL because you can get the information that you need from the blood. Sometimes you can't. Sometimes people don't have enough of a lymphocyte count that the genetic tests just there's not enough cells in the blood to run the genetic test. Well, in that situation, you need a marrow. Sometimes we're worried that somebody has something else going on in their bone marrow, especially with the older treatments like FCR. They can damage the cells that produce blood. And sometimes, you see changes in the blood, and it's not that their CLL is growing, but it's the fact that they've developed other conditions like a myelodysplastic syndrome from the effect of their previous treatment on the bone marrow. So all of that to say that we don't always do imaging tests or bone marrow biopsies in CLL unless there's a reason to do them. PET scan is the other one that comes up all the time. Why am I not getting a PET scan? Well, a PET scan at the end of the day is a test like any other. And so I might do a PET scan if I'm worried that there's a Richter transformation. I might do a PET scan if I'm worried that there's an area of lymph nodes that's taking off while everything else is constant. A PET scan might help me direct a biopsy to understand a particular situation where something is growing and I don't fully understand if it's CLL or if it's a Richter, or I want to understand the biology, the genetics of why this is changing. So I would say, based on all of this, the day-to-day management of a patient with CLL in terms of investigations, is relatively straightforward because most of the information you can get from blood work, but yes, you need to do other tests along the way. So you've done all of this, and then you're at the point of treatment. So this, I think, applies mainly to newly diagnosed patients, but it also applies at the point of therapy. So when you think about the bigger picture of treating a patient with CLL, well, what are the goals of treating CLL? Like, we all know that CLL is incurable with current therapies. So the goal here is, how do I maximize quality and quantity? How do I use the tools available to me to maximize these two endpoints? And so the first decision-making point is, so this is from Lymphoma Canada. How will my CLL be treated? Well, do you need treatment? Or can we sit on it? So we're talking about those indolent CLLs on the left side of the slide. Can we just let them grow for a little longer because this patient doesn't necessarily need treatment right away? And you wait until there's signs of symptoms of progressive disease, and then they go in here. And then patients get treatment. And then if people respond and they go into remission, great. Unless they're in continuous treatment, then you keep going with their continuous treatment. If they don't respond, you do additional treatment. But you can see how the first break in the line here is there an indication for treatment, yes or no? And again, this is true too at relapse. You treat someone, you see their CLL is starting to progress. You don't necessarily have to jump into treatment. The moment there's a little bit of progression, you can usually write this out for a little longer. So how does one decide when to pull the trigger on treatment? Well, the good news is we have criteria for that. And so we have the IWCLL guidelines, so the International Working Group on CLL. It's the same group that provided the guidelines on the CT scans and the bone marrow biopsy that I showed a moment ago. So, well, you got to quantify this somehow, right? Like, you can't just say, well, treat them when they're sick. Treat them when their blood counts are off. You have to provide some quantifiable parameters that you can use to help you in your decision making. And so the typical criteria to treat someone would involve large nodes. Not necessarily, I would never wait for a node to measure 10 centimeters, but if there's sufficient volume of disease, if they're compressing organs like the ureters, the airway, then that needs treatment, even if the node measures 3 centimeters. Sometimes you have to treat because of an enlarged spleen. The spleen loves to eat red cells and platelets. And so sometimes you have to treat it because of that. A very large spleen can rupture. Enlarged spleens can cause pain. Enlarged spleens press on the stomach. And so people lose weight because of good old just filling. There's just no room whenever they eat. So they can have nausea, vomiting, and all of these things. Low blood counts. And so the parameters here are a hemoglobin less than 100 in our world, 100 for platelets or low neutrophils. We treat when things are growing quickly, when the lymphocytes start to double quickly, when the lymph nodes grow quickly, when patients start to lose weight and they're tired and they have fevers and sweats with no clear cause, with no clear infection, that needs treatment. Those are harder to quantify. Sometimes CLL can cause autoimmune conditions because, remember, this is an immune system disease that produces antibodies, and these antibodies can activate the normal immune system in the wrong way. And so it's very common, actually, to see things like an autoimmune thrombocytopenia or an autoimmune hemolytic anemia in the context of CLL. So it's not that the CLL is growing like crazy, it just triggers the immune system to destroy platelets, red cells, or other cells. Basically, any symptoms that are affecting quality of life, and we always treat a transformation to an aggressive lymphoma. So those are the things that I look for when I'm seeing a patient in the clinic. I might not be saying it to you, but I'm looking at it. I'm kind of running the list every time I see somebody in the clinic. Do we need treatment? Are we good? Are we not good? But, on this business of watch and wait, it's I hear this every time I make a recommendation for watch and wait. And this is not true just for CLL, by the way. We observe follicular lymphoma, we observe mantle cell lymphoma, we observe lymphoplasmacytic lymphomas, we observe marginal cell lymphomas. And so across the board, there's always a bit of an anxiety in the room. And they say, you're just going to sit on my cancer. You just told me you have stage 4 and you're going to sit on it. And so some people think, this is a time bomb. Something bad's going to happen. Other people are relieved. And they say, yay, I don't need treatment. So it's a bit of a mixed feeling here. And it's a learning process. I will say it's a learning process. Learning, this is part of survivorship, and part of learning to live with chronic lymphocytic lymphoma is to understand that this is not a one-time decision that is made, but it's part of a much more complicated longitudinal decision-making situation. When I speak to the students, I often say to them, this is like a chess game, okay? You gotta be real careful about how you move your pieces, because the way you move your pieces will influence how you move your pieces, and it's also gonna influence how the CLL moves its pieces. So it's not so simple. And the other thing is, remember, CLL is incurable today. We have a lot of tools in CLL. We have more tools than we've had ever before. We have BCL2 inhibitors. We have a whole bunch of different BTK inhibitors. We have different CD20 monoclonal antibodies. We have BTK degraders coming. We have CAR T-cell therapy. When I started 16 years ago, I didn't have any of this stuff. When I started 16 years ago, I had chemotherapy and rituximab. While that is great, it's not an infinite list. So we cannot burn out all of our silver bullets at diagnosis, because then what are we going to do when we need them later on? There's also studies showing that treating CLL early does not prolong survival. Now, that's with older therapy. Studies looking at more novel therapies are being done, but that's what we have right now. And the other problem is resistance and clonal evolution. So if you treat somebody unnecessarily or prematurely, you got to be prepared to deal with clonal evolution that may or may not affect your subsequent lines of therapy. There's some emerging data that with these time-limited first-line therapies like I plus V or V plus O, you don't necessarily cause clonal evolution. But do you know for sure? No. And the other argument, and I have seen this in my career, is you may have potential access to first-line therapy. So a patient diagnosed in 2010 who managed to, live for 15 years, all of a sudden did not need FCR and was able to benefit from venetoclax or BTK-based combinations. So that's pretty valuable. So those are the arguments made in favor of active surveillance in CLL. Okay. So in general, I would say that about a third of patients that I see for their first consultation will need treatment right away. A third will never need treatment. That's pretty amazing. And the other third, you can observe for a period of time, and eventually they need treatment. So according to these statistics, 2 in 3 patients with CLL will never need treatment. I personally think it's different. I personally think probably 3 in 4 will need treatment at some point. But just to give you a sense of what this is, first-line therapy with watch and wait. But again, it just goes to this business of the heterogeneity of the disease. We had talked about the CLL IPI. And so you can actually use the CLL IPI to estimate who will need first-line therapy and who will not need first-line therapy. So we had already talked about the 5 factors. And so you can see, for example, if you have a low CLL IPI, so this is time to treatment, time to first-line CLL therapy. Not everybody needs treatment with a low CLL IPI. If you have a high or a very high, almost everybody does. So it's kind of a nice, kind of rough way of estimating who will need treatment and when they might need treatment. But that's just an estimate, right? Every person's different. These are population statistics. And so when we do active surveillance, it's not that I discharge you back to your family doctor and I say, call me when you have problems. No, with active surveillance, it's active. So patients need to be seen. You need to monitor blood counts. You need to monitor for all of these symptoms that I talked about. And you also need to insist on the survivorship aspect. Are we dealing with infections? Are you getting your skin checked? Are you seeing your GP for your mammograms or your colonoscopies and all of that stuff? If you're having frequent infections, you need to deal with that. You need to encourage exercise, and you need to be prepared to treat the CLL at the time of symptomatic progression. So it's not as simple as just saying CLL, off you go. It's a very complicated disease with many phases, different presentations, very heterogeneous biology. Despite the complexity, the clinical the day-to-day management for the most part is very straightforward, and we have guidelines that help us a lot in terms of how do we move a patient's care over time. And the bad news is that CLL is incurable. The good news is we have an increasing array of therapies, and I'm quite optimistic that outcomes will continue to improve over time. So thank you very much. I hope that was helpful.
Thank you very much, Dr. Villa. That was a whirlwind through some complicated concepts. So thank you for trying to make them a little less complicated and a little more familiar. We have time for a couple of questions. And also, please remember, if you have questions, you can jot them down on the piece of paper as well, which we can do and try to answer during the physicians panel. But we do have time for a couple of questions.
Go ahead, Luis.
Hi, this is the ambassador from Belgium here. I've always been curious about the chromosomal deletions, and one of my questions is, how present is that in other cancers? Because I only know about CLL, but I don't know about the other ones. Is that something in other kind of leukemias that is looked at?
Yes. So the answer is yes. It's something that you can see in other cancers. So take a step back. So this business of chromosomal deletions or extra copies of chromosomes is this I shouldn't say very old, but it's kind of an older technology called karyotype. So this is technology from like the 70s and 80s, where people would like break up white cells and look at the little chromosomes. You know how we all have 23 chromosomes and XX, XY. So they kind of line them up, and you kind of count them and you see if the shapes are maintained, if they have the little arms and the long arms and all that stuff. And so it was observed early on with CLL that there were recurrent changes in some of these chromosomes, so that, for example, chromosome 17 would lose a little arm, chromosome 11 would lose a little arm, and in some patients who did really well, they had, extra copies of 12 or whatever. And the reason it's taken off in CLL is because you can do this easily in peripheral blood. You can also do it in a tissue, but blood is so easy, right? You just go to the lab, you isolate the DNA, and you cut and paste, and you do your little karyotype. But if you think about it, it's a relatively old methodology. You can do it by newer technologies like fluorescent in situ hybridization, where you're looking specifically at the changes that you know. But that gives you limited information. It just tells you that the short arm of chromosome 17 is missing. So what? What really matters is that the TP53 gene lives in the short arm of chromosome 17. And when you lose your P53 gene, that's when the bad stuff happens. The ATM gene lives in the long arm of chromosome 11. When you lose the long arm of chromosome 11, ATM is lost, bad CLL. So where I'm going with this is that karyotype or FISH is a proxy for a genetic mutation that's running the show. So we do it in CLL because it's easy. It's cumbersome to do it in solid malignancies. It's cumbersome to do it in lymphomas. It's cumbersome to do it on a biopsy. And these days we have sequencing, which goes directly at the gene mutation rather than the chunk of DNA that's lost. But yeah, P53, for example, is a recurrent mutation across all of oncology. So mantle cell patients with a TP53 mutations do very poorly, just like a lung cancer patient with a loss of TP53 does very poorly. Question?
Yeah. Good presentation, by the way. Thank you very much. So just in one of your more offhanded comments, you mentioned acalabrutinib once, just not part of your main presentation, but aside. So when treatment is required and some sort of therapy is required, is acalabrutinib is it cutting edge and a go-to therapy now? I don't know if that's too general. Maybe, top 3 therapies that you use, so to speak, but what's your top 10 hot list?
3 comments. I mentioned acalabrutinib because it's the first one that came to my mind. There's also ibrutinib, and there's also sanubrutinib, and there's also pirtobrutinib. I just said acala because I'm here and I'm nervous. Second comment, BTK inhibitors are cutting edge. BTK inhibitors have drastically transformed the way we treat CLL and other B-cell malignancies. BTK inhibitors are a luxury item. These are expensive drugs. I grew up in Colombia. I recently gave a talk down there. Access to any BTK inhibitor is luxury down there. So don't forget the big picture, that around here we are ultra blessed to have access to CAR T-cell therapy, bispecific antibodies, BTK inhibitors, and all of that.